Welcome to Forum 360. I'm your host, Leah Love, where we have a global outlook from a local view. I'm so excited today to talk about a very important subject. So with me, I have Dr. Cody. Thank you for joining us.
Thank you for having me.
I want to read just a little bit about him because he's a remarkable surgeon. So I want you to know who we are talking to today. He's made an extraordinary impact in the world of breast reconstruction. Dr. Derek Cody is a board-certified plastic and reconstructive surgeon with Crystal Clinic Plastic Surgeons, renowned for his expertise in advanced microsurgical techniques, especially the DIEP Flap procedure, which offers women a natural implant-free option for breast reconstruction after a mastectomy. He's been recognized among Cleveland and Akron's top doctors. Dr. Cody is known for his deep commitment to patient care. He's also a pioneer in procedures like facial reanimation and targeted muscle reinnervation, bringing innovative options to Northeast Ohio for the first time. I'm honored to have you today, and this is going to be a very insightful conversation about breast reconstruction options. So with that, tell me a little bit about your background and what drew you specifically to breast reconstruction.
Well, thank you for that very kind introduction, and I'm excited to be here. So, as you said, I'm a board-certified plastic and reconstructive surgeon, and I specialize in aesthetic as well as reconstructive surgery for men and women. I'm very proud of my commitment to breast reconstruction. I get to help women who have been diagnosed with breast cancer. This is something that all of us will face in our lifetime. There's over 200,000 breast cancer survivors around, and it's important to offer them some form of reconstruction so that they can get back to the lives that they led before they were diagnosed. So this is something that I hold near and dear to my heart. We all have women in our family, and someone will need this at some point in time. So as a board-certified plastic surgeon, I went to medical school at the Ohio State University, College of Medicine. Afterwards, I spent 6 years of plastic surgery training and advanced microvascular surgery training as well. And I've been in practice for just over 16 years.
Okay. So over the span of your career, what are the advancements that you've seen in terms of breast cancer reconstruction?
So we've had a lot of advancements, and I'll start a little bit before my career.
Okay.
So we started in the 60s and 70s with implant-based reconstruction. And that was great because now we had an option to restore form. And from there we realized that implants are great for some patients, but sometimes they're not great for everyone. And so we started looking at tissue options. And so one of the early tissue options was to use the abdomen as a tram flap, but that surgery required sacrificing the rectus muscle to make the breast. And so we realized that some women didn't do well after a tram flap because they didn't have their stomach muscles there. Mm-hmm. It's important to have those muscles for, preventing back pain as you age and evacuating your bowels and bladder. So we tried to innovate and become better. And as we learned how to do microsurgery and became experts at that, we realized we can use the same tissue from the lower abdomen without taking any of the muscle or the nerves to the muscle, so that when we're done, the patient has a breast reconstruction as well as a functional abdominal wall. So it's really the best of both worlds.
Ooh, that's amazing. What advances are you most excited about?
So there's lots of advances in plastic surgery. We're doing a lot of fun things with stem cells and fat grafting to help recondition tissues and provide volume. We're looking at robotic surgery for some of our flaps. We're looking at just an array of different things. In plastic surgery, we like to think of ourselves as innovators. We kind of figured out a way to do a face transplant through our expertise in microsurgery. So I do a lot of other surgeries like TMR, which helps to, it was something that was born out of the military. We were looking at ways to help amputees control myoelectric prosthetics, and we found that it also helps with phantom pain. So that's some nerve transfer surgery that really is helpful for patients who have a lot of pain and want to control the myoelectric without some of the older types of prosthetics.
Now, I'm not sure if this affects you or not, but I know there's a lot of talk about AI. Is AI a factor at all in any of these areas?
Well, certainly, I think AI will help us as we kind of fine tune our algorithms for patient selection. And you know, I still think at the end of the day, as a surgeon, you have to be the one in the operating room with the skills to kind of complete the task.
Mm-hmm. So you cannot be replaced.
Hopefully.
What are the different types of breast reconstruction procedures that you offer that people can take advantage of?
So again, I offer implant-based reconstruction for patients who are ideal for that, and sometimes it's patients who have, you know, really busy lifestyles and young moms who are still caring for kids and they don't have the 6-8 weeks of recovery that you have for a flap surgery.
What's that recovery usually?
It's also about 6 weeks, but it's only at the breast.
Okay.
You know, when you do a reconstruction using your own tissue, there's 2 sites: the surgery site, which is the breast, and the donor site, which can be the abdomen. It could be the thighs or buttock as well.
Okay.
So there's a little less recovery with an implant-based reconstruction. However, there's a little more maintenance long term with implants versus a flap. So implants are great for the right patient. I also offer the DIEP Flap, which is from the lower abdomen. Sometimes patients who had surgery in the past aren't candidates to use their abdomen, so I can use their inner thighs as well, the buttock, the back, and so there's just a number of different options for patients to use their own tissue for breast reconstruction. Those are the most common sort of types, implant versus flap, and timing is whether it's immediate or delayed.
Okay.
Most patients who aren't candidates for radiation can go with immediate breast reconstruction, and that could be with an implant or a flap, like the DIEP Flap. In the setting of radiation, we tend to do delayed breast reconstruction more often, and I tend to, in my practice, avoid implants in those patients.
Okay. Is there a difference as to why one would do radiation versus chemo?
Yes, so oftentimes as a part of the treatment for breast cancer, we meet in these multidisciplinary groups where there's a breast surgeon, an oncologist, a radiation oncologist, a plastic surgeon, and some support people as well. So we come up with, you know, we look at the type of tumor, the size, the location, whether there are any lymph nodes involved. So tumors of a certain size are candidates for chemotherapy and radiation. If there's lymph node involvement, those patients are candidates for radiation. So early cancers sometimes don't have those additional features, and they may just need a partial mastectomy. Okay. And other patients will need a complete mastectomy.
Okay. All right, so what are well, you just talked about the advantages. What kind of health or lifestyle factors would disqualify someone from getting a DIEP or maybe an implant, any of those? Well,
so we often look at the patient's overall health, and so when I meet with someone, we do a nice long history and physical exam. We talk about what their goals are, what their needs are. I tell patients, you know, smoking is going to delay your healing, so we encourage patients who are smoking or using tobacco products to stop as early as possible. We want the best outcome, we want the best healing, we want to avoid any complications. Sometimes previous surgery will change what you do as well. Again, if you've had surgery on your abdomen, you may or may not be a candidate for a DIEP flap. However, I should let everyone know that most patients who've had a C-section or a hysterectomy, they're still candidates for a DIEP flap. Okay. So, you know, just looking at the patient, talking to them, figuring out what their individual needs are will kind of help us determine if they're going to be a candidate for a DIEP flap or not. You know, we look at your heart, your lung, your liver, your kidneys to make sure they're in good enough condition to tolerate the procedure. Okay. And then we do something that's safe and effective.
Okay. Is there an age limit for, like, maybe, what's the youngest patient you've seen?
The youngest, I've done patients in their mid to late 20s.
Okay.
And probably the oldest DIEP flap was a patient in her mid-70s.
Okay.
And she was so happy afterwards and wished she had done it years sooner. But it's all about looking at the patient, making sure they're safe candidates for surgery, and that means, you know, checking out the heart, liver, lung, kidneys, making sure they're all working in order, and then you can proceed safely.
As far as the age ranges, are you seeing a shift in ages from what you prior have seen, and what has that shift been?
So that shift sometimes is really, you know, we see a little bit younger patients. I hope this is more, you know, related to early diagnosis and catching people at an earlier stage, but we are seeing some shift to a little bit of younger age group.
Okay. If somebody came in for a consultation, what could they expect for the consultation?
Yeah, so our consultation, we go over a lot of information, and so I recommend all patients who are having a consultation with myself or any physician, bring someone else to help listen. Do your homework before you come.
And what could that include?
So that should be researching your surgeon to see if they offer what you need. And looking at either before and after photos or talking to patients who've gone to this person, and just figuring out if they offer what it is you're looking for.
Okay.
And then come with a list of questions and come with someone to help you kind of listen and take notes. Never be afraid to get a second opinion if you don't feel 100% comfortable with the physician you're talking to. Most docs, if not all, should welcome you having a second opinion. So I always welcome patients to come back, ask questions if something's not clear, and a second opinion is never a bad thing.
Okay. Now, are there any places that they can look for if they want to talk to previous patients, if they're not sure how to find some of that research information?
Yeah, so there are lots of forums out there, and sometimes those forums allow you to communicate with patients through electronic mail. Through our office, we do have patients who have said they're willing to talk to new patients to help them make this decision. In October, we also do our Pink Runway, where we have our breast cancer survivors kind of walk the runway. But a part of that is we educate patients and their families about options, and they make their own friend networks, and they talk and communicate throughout the year. And so that's a good way to meet people who've gone through this before you and people who may be coming behind you as well.
Yeah, that's amazing. And if you are just tuning in, we are talking to Dr. Derek Cody with Crystal Clinic Plastic Surgeons about breast reconstruction. So I love that there is an option that people may not know of, a way to start to build a network and just even talk to people to find out more about your research and your options. So what role does 3D imaging or any other visualization tools help with patients understand their options?
So 3D imaging can help to get an idea of the outcome. However, I think oftentimes before and after pictures are similar and allowing patients to see what things look like. Because before and after pictures, you're actually looking at a person and not a rendering of a person. And you can see some of the highlights, and you can see some of the early healing versus the late healing. I think that's important for patients because oftentimes we look at the end result and we don't know how patients got there. So it's nice to come in and see some follow-ups at 1 month or 3 months and 6 months or a year. And that way patients know there is a healing process that everyone goes through.
Mm-hmm. So how many surgeries typically would vary between each procedure?
A great question. So breast reconstruction is really kind of individualized to the patient. And I tell most patients it is a staged process. So sometimes we do nipple reconstruction for completion, and then there's tattooing of the nipple. So those are also procedures that are kind of part of breast reconstruction. Oftentimes we'll talk to patients about symmetry. So if it's a patient who had one surgery on just one breast, they may want symmetry. Most likely they will on the other breast. So sometimes that's a lift, it's a reduction, and some matching. So there may be some matching of the two breasts.
Have you had any candidates or any patients that you've had to turn away, they just were not a candidate?
You know, the nice thing about breast reconstruction, and someone who does a lot of breast reconstruction, usually we can find an option that works for you.
Okay.
Sometimes it's an implant.
Okay.
Sometimes it's a DIEP flap where we use your abdomen. If you're not a candidate for the DIEP flap, sometimes it's a inner thigh flap. Sometimes it's a lumbar flap from the back, or innovative surgeries from different parts of the body. So it's really nice to be able to offer something for everyone.
Okay, perfect. So here's a question. Actually, these next couple questions are from the community.
Okay.
They wanted to know. Should a woman who's had reconstruction still get mammograms and cancer screenings?
So that's
not reconstruction, I'm sorry, a mastectomy.
Right, so most often after a mastectomy, mammograms aren't necessary because you've had a mastectomy. Okay. However, a self-exam by yourself, weekly, monthly, is something that we still recommend, and certainly a clinical breast exam yearly with your breast surgeon or your plastic surgeon, we tend to see patients throughout survivorship as we make in-depth relationships with our patients. If you have an implant, you come back really kind of yearly to check the implant. At a certain time, it's recommended that you have some surveillance to make sure the implant is still doing well. So that's another opportunity for you to see your plastic surgeon, who will do an exam, feel for anything that's changed or new, and certainly order the imaging that's appropriate for your implant. With flaps, we tend to finish our reconstructions sooner. There's less late sequelae, but we still see those patients. I have patients that I've been taking care of for years, and sometimes we just have a good relationship. They come in and we talk for a little while, and that's all we do.
That's awesome. Okay, the next one is, I heard that if you get a mammogram, it will give you cancer.
So again, mammograms have a small amount of radiation that is associated with them. However, it's kept to a minimum, and it certainly finds many more cancer than it will ever initiate.
Thank you so much for answering that, because I was amazed at how many people I've heard that question from, and I just had never heard that before. Mm-hmm. But it was a question I started hearing more frequently, so I said, I gotta make sure I ask him. Can I still smoke after surgery?
So I'm really glad you asked this. One, because we do see people who smoke, and we have to counsel them. Look, if you stop smoking around surgery, don't pick it back up, because it's going to help your heart, it's going to help your lungs, it's going to help you live better well after you've healed from surgery. Mm-hmm. I tell patients all the time, so your vessels, we need them open to help with the healing process. And smoking causes the vessels to narrow and harden. And if you can't deliver the groceries to the cells that need it to heal, you can't pick up the waste products that they make every minute of the day, you're creating a scenario where wound healing is going to be poor and suboptimal. And we want the best result. So if you stop for surgery, just keep going.
Keep going. Let's see. As far as cost, is plastic surgery or reconstruction covered under insurance, or is that usually private pay?
So the Women's Health and Cancer Rights Act was passed in 1998, and it guarantees women the right to have breast reconstruction if they've had surgery for breast cancer. So your insurance company will cover this for you. They also cover those sort of symmetry operations with the contralateral breast as needed as well. So this is something that's covered. So initially we saw rates that we didn't expect after the passage of that law, and it was less than we thought. And so we realized that some patients were not being made aware by their surgeons or breast surgeons or other doctors that they have the option to have breast reconstruction. So the Breast Reconstruction Awareness Act was passed in 2015. This mandated providing doctors to let their patients know that they have the option to have breast reconstruction and to make referrals as indicated.
So it's a mandate now that the doctor should be telling you that this is an option.
This is an option for you, yeah. There was a time when it was like, we're going to solely focus on the cancer, and then, if you want to do that a year from now, that's kind of up to you. But now we realize we've done studies to show that women do much better when they have reconstruction. Particularly, it's good for their emotional makeup. It's good for their psychological makeup. It's good for their physical makeup.
So when you talk about psychological, is there ways that you help prepare them for surgery and for this process and for post after the surgery?
Yeah, I mean, so with me again, my consultations are long, because I try to give patients time to kind of take in as much as they can about what we're talking about, and I let them know it's a process. You're not going to wake up after the first surgery and go garden. You're going to heal. You're going to take some time. You're going to rest. There's swelling. We'll have to give your body time to resolve the swelling. There's a healing process. So I prepare patients that we're going to work through this together. It's going to be a year before things are finally settled down, but most of it's settled in a few weeks, but there's some fine things. Your body takes about a year for it to kind of really remodel a scar on the inside. And so what we see on the outside is the tip of the iceberg. So there's a lot of work going on the inside that takes a little time. And as that scar remodels on the inside, some of the tightness goes away and you feel much better. And so there's a process.
Okay. So someone has had a surgery and it got botched. Can they get that fixed, and will insurance still cover that? Do you know?
Oftentimes it will if there's a revision to the reconstruction that's necessary, absolutely. And again, we talk about doing your homework before you see a surgeon to find out who's the most qualified and for what you're looking for. And so patients really have to be their own advocate. Oftentimes you want to know, a referral doesn't mean you're obligated to go see this physician that you were referred to. Do your own homework and find out who you want to go see yourself. You
just said advocate. What else is your advice for people to be a better advocate for themselves? Because it can be kind of intimidating.
Yeah, it's a great question. It's a great question. So I think in the end, this is your one life. Do everything you can to advocate for it. And again, the doctor-patient relationship should be one of mutual respect. And if you don't feel that mutual respect, then it's time to advocate, and it may mean seeing someone else. And so, again, going into things with as much knowledge as you can will help you figure out. It's a difficult thing to figure out, but you should be welcome to come back with questions if needed, and just realize that you're not being confrontational. You're just looking out for something that you haven't much experience with, because hopefully you don't have experience with this ever again or before. Mm-hmm. So, but as the physician, we have the experience. We do this every day. So it's on us to present this information in a way that it can be understood and welcomed for additional questions.
Are there any local organizations or groups, resources that you could provide to people that maybe they should look into as they're going through this journey and process?
Yeah, so there's, one of them. I think there's lots of organizations that are working in this space to help women to find, friends who've gone through this. There are lots of organizations that are dedicated to treating anyone with cancer, and we have them in Northeast Ohio, and they're great resources to go and find friendship, support. Some of these organizations provide clothing, they provide wigs, some of them provide bras, some of them provide some counseling services, ways to kind of grow beyond the surgery and remain positive in what you're doing and things like that.
Perfect. Let's talk a little bit about nipple reconstruction. Mm-hmm. Tell me the pros, the cons, what can they expect about look, feel, sensation?
Okay, good. So nipple reconstruction is one of the last things we do with breast reconstruction, and we do that when the breasts have the optimal form, shape, and volume. But nipple reconstruction really completes the process. And I can't tell you how many patients come in thinking, I don't need nipple reconstruction. But when they have it, they're like, oh, this was great. I'm so glad I did it. I feel so much better. Mm-hmm. I feel whole. And so I really tell patients, you don't have to make a decision about nipple reconstruction now. Let's mm-hmm. go through the process. And I can't tell you how many people come in and say, wow, I'm so glad I did this. I look in the mirror and I see a whole person again. So it's one thing to be able to put on clothing and look complete, but sometimes you want to look complete when you look in the mirror too. So mm-hmm. sometimes I make nipples out of the tissues that are left, either from the mastectomy skin or the flap, and oftentimes patients will opt to tattoo the nipple and the areola afterwards. I used to do my own tattooing of the areola. I don't anymore. I think the people who specialize in it do a much better job of it. They have more sophisticated instruments than I had in my office, so I'm glad to refer patients out for nipple tattooing. 3D nipple tattooing is really popular now, and that allows women to have a tattoo without a nipple that projects but has the appearance of projection. So that really helps to complete the appearance, mm-hmm. But it doesn't have the projection. And so that's a great option for patients to do here locally. And so I think it's so important for women to know that, before you make a decision on nipple reconstruction, go through the process, because most women come in and say, this was really the icing on the cake.
All right, in our final 30 seconds, anything you would like for our audience to know, be made aware of, if you have a story that really touched you over these years?
You know, I've had so many touching stories, and what I really want people to know is, find someone who you connect with. This is a journey. Breast reconstruction is a journey, so make sure you do your homework. Again, if you need a second opinion, don't hesitate to do it. Feel comfortable with your doctor, because it is a journey. It's going to be some time spent with this person, and you want to feel confident that they can get you to where you want to be, and enjoy the journey.
Thank you so much for your time. I really appreciate it. You gave a host a wonderful amount of information. I hope you all will use this information to make better informed decisions. If you need to contact Dr. Cody, he is at Crystal Clinic, Plastic Surgeons. And I am your host, Leah Love, where we have a global outlook from a local view on Forum 360. Thank you. Have a great week.
Forum 360 is brought to you by John S. and James L. Knight Foundation, the Akron Community Foundation, Hudson Community Television, the Rubber City Radio Group, Shaw Jewish Community Center of Akron, Blue Green, Electric Impulse Communications, and Forum 360 supporters.